The conversation this evening will aim to highlight key learnings from the overall pandemic response and implications towards building health system resilience from the lens of healthcare workers as well as the public health system at large. The discussion will include learnings across primary healthcare delivery, innovations and digitization, diagnostics, better preparedness for the future health emergencies, as well as the overall health system resilience. We are really excited to start the discussion today. Joining us, the moderator for this evening is Dr. Angela Chaudhuri. Dr. Chaudhuri is the director at Swasti Health Catalyst. She has over 21 years of experience in public health in India and internationally. She's a partner leading the health practice in the Catalyst group of organization and leads the health response of COVID Action Collab. From evaluation of several countries' national health programs to research, Dr. Chaudhuri works very closely with various stakeholders and has globally co-designed interventions. Joining Dr. Chaudhuri, we have four wonderful panelists for today. I'll start with Dr. Thelma Narayan. She is a Senior Advisor, Academics and Health Policy Action at SOCHARA. She is an epidemiologist, health policy analyst, and scholar activist who was the director at SOCHARA School of Public Health Equity and Action. She is also a member of Advisory Group on Community Health Action for Health in the National Health Mission and is currently a member of Lancet Citizens Commission and has to her credit a large number of reports, publications, and papers. Next, joining us, we have Mohammad Ameel. Mohammad Ameel is currently heads the primary healthcare technology and innovations portfolio at PATH India. He has previously also worked with international organizations and ministries in India. He's a founding member of Health Technology Unit at WHO Regional Office for Southeast Asia and was currently conferred with a prestigious award of 100 Most Impactful Healthcare Leaders. Next, we have Dr. Taslimarif Saiyed, who is the CEO and Director of CCAM, an initiative of the Department of Biotechnology, Ministry of Science, Government of India. Dr. Saiyed heads the Discovery to Innovation Accelerator Program at CCAM and is currently involved in promoting innovation in healthcare space. He's also the adjunct faculty at IIT Madras and Amrita Institute School of Biotechnology. Last but not the least, we have Madhavi Roy, who is a research coordinator with the Thrive project in the Sangath Bhopal team. She's a global mental health researcher and is also the facilitator of the mental health subgroup at the Global Gender and COVID-19 Working Group, where she's studying the psychosocial impact of pandemic on LGBTQIA+ communities. We are grateful to all the speakers for joining us for this critical discussion today. And without further ado, the format of the session is such that we'll begin with a 15-minute video that captures the voices of organizations and healthcare workers from the ground and helps set the tone for the upcoming discussion. Following the video, we will move on to Dr. Chaudhuri, who will moderate the panel discussion. In the end, we will have 20 minutes for the Q&A session. I would request everyone to please leave your questions and comments in the Q&A box through the discussion, and we'll take it up later. Thank you.
Hello and welcome to CoreNet Online 2022, where we discuss learnings on resilience and resurgence from 2 years of COVID-19 in India. In today's session on health systems resilience, we will hear stories, experiences, and challenges from a range of stakeholders in the country's primary healthcare ecosystem. World over, the World Health Organization's 6 building blocks have been acknowledged and used for thinking through an effective and balanced healthcare system. These 6 building blocks signify the importance of a sound healthcare system and ensure its well-functioning and efficient service provision to meet the health needs of people across the globe. However, the pandemic brought to light key challenges and in some cases deepened the fault lines in India's health system. Having said that, there have also been certain bright spots and learning opportunities that have paved the way for the future of a resilient health system. Dr. Angela Chaudhuri is a director at Swasti, an organization dedicated to innovating solutions for transformative health impact. She explains how the pandemic brought together a diverse range of individuals from various sectors for the greater good.
There's a renewed understanding of what is public health and what public health can do, and therefore everyone jumped into the hat. Earlier it was just limited to clinicians and social workers, but really public health had a way of unifying. The COVID pandemic had a way of unifying what would be redefined as public health, and it included epidemiologists, researchers, academia, scientists, private sector players, small clinics, diagnosticians, a lot of digital startups got into the game as well and supported people. Philanthropists, those who hadn't added health or public health or population health on the mandates added that, private foundations, and lots of unlikely partners, which is great.
Primary healthcare is a whole of society approach to health and well-being that is centered on the needs and preferences of individuals, families, and communities. It focuses on the comprehensive and interconnected aspects of physical, mental, and social health and well-being, as well as the broader determinants of health. Primary healthcare includes three components: meeting people's health needs, systematically addressing the broader determinants of health, and empowering individuals, families, and communities to optimize their health. A strong primary healthcare system is essential towards not only achieving Sustainable Development Goal 3, but also several other SDGs that rely upon a healthy society and environment. Unfortunately, though, primary healthcare services in India face several challenges, which were further exacerbated by the COVID-19 pandemic. It negatively impacted day-to-day healthcare services, especially those that impacted women, children, and other vulnerable groups. While the healthcare system was struggling in trying to contain the spread of the virus, ASHA workers were on the front line, risking their lives to protect those of others. To dive deeper into challenges faced by primary healthcare workers, we spoke with Ms. Bhanupriya Rao from Behan Box, a bottom-up evidence-based journalism and storytelling platform, and with Sunita Ji, an ASHA worker from the Sonipat district of Haryana.
The whole hierarchy of in the healthcare system, you see that during the pandemic, you couldn't have done without this category of workers. And yet, when it came to the responses of the state, they were really at the lowest end, as they always have been at the lowest end of the hierarchy. So, or lowest end of even states' care and rights.
Healthcare workers were the lifeline of rural communities during the pandemic. And even after delivering first contact healthcare in this period, they struggled to gain recognition or even fair remuneration. Let's hear from Sunita ji.
तो एक आशा को कम से कम 8 से 10 घंटे घर से बाहर रहना पड़ता है। फिर जितना हमें इंसेंटिव इसका मिलना चाहिए वो इंसेंटिव नहीं मिलता है। प्लस में जो हम इधर उधर बाहर आते जाते हैं, घूमते हैं, उसके लिए टीएडीए भी कोई प्रावधान सरकार ने नहीं किया है। 2 से 3 दिन भी कई बार हमारे खर्च हो जाते हैं, उससे हमारे दूसरे काम प्रभावित होते हैं। फिर परिवारों में समस्याएं खड़ी होती हैं, भाई वो सबको रोटी की जरूरत है और परिवार तो महिलाओं के बिना चलते नहीं। अनेकों तरह से हम प्रताड़ित होते हैं।
This has been a real challenge. India's health system was stretched to the breaking point many times during the pandemic, with the bulk of the care burden on ASHA workers.
You know, in Karnataka, there were many cases. They documented about 100 such cases. In Haryana, these two states were particularly, disturbing accounts of violence. In spite of government invoking the Epidemics Act that violence will not be tolerated against healthcare workers, but there was really no redressal mechanism for them. So all in all, it was an exploitative system for ASHA workers turned even more exploitative. So many ASHA workers we talked to, they said that we are made to feel like we are not even part of the healthcare system, like we are not part of the health departments. So you keep talking about corona warriors, and those days people were banging thalis and, honoring the healthcare workers. So if you keep talking about corona warriors and you do not even pay attention to, so are we not corona warriors? So are we not important enough? And that means that these ASHA workers, very sadly, but also very annoyingly, really, are treated, and in their own words, are treated as worms. This is not something that I'm making up. This is exactly the term used by one Asha worker from Andhra Pradesh who I will never forget, who had a little quake in her voice when she told me, we are considered as worms by the system.
Underpaid, overworked, and overburdened, Asha workers fighting COVID-19 in rural India were thoroughly overlooked. The pandemic not only increased the workload of the average Asha worker while stretching their finances, but the difficult working conditions exacerbated work-life imbalance, leaving them in the middle of an unfolding mental health doom.
तो कभी भी जो है उस तरीके से सपोर्टिव सिस्टम हमारे लिए अभी तक तो क्रिएट हुआ नहीं है। देखिए उस वक्त में असल में सरकार को भी हमें सपोर्ट करना चाहिए था। हमें जो है इस बीमारी से निपटने के लिए फुल ट्रेनिंग देनी चाहिए थी, सारी सुविधाएं उपलब्ध करवानी चाहिए थी, और जो हमारा दायरा है काम का, जिस खतरे में हम रहते हैं उस पे हमारी सामाजिक सुरक्षा और हमारे पीछे हमारे परिवारों का क्या होगा, जितना काम का बर्डन है, जितने सफर में हम रहते हैं, जितनी मानसिक दबाव हमारे ऊपर है, तो उससे हमारी कोई सुरक्षा नहीं है। उसना कोई वेतन जो है सरकार उसके रूप बदले में हमें नहीं दे रही है, और जिस तरीके से शोषण कर रही है उस तरीके से जो है हमारे साथ केवल शोषण ही हुआ है।
Challenges raised by Bhanupriya and Sunita ji clearly demonstrate stress and burnout that frontline workers have experienced. While they made significant contributions to the state's response to the COVID-19 crisis with limited resources, they were not afforded basic human rights or access to physical and mental health services.
Hopefully there will be a change, is really the emotional and mental health support. That not just for frontline workers, but also clinicians. There's a huge stigma about doctors wanting and getting mental health. That's actually an issue that I would like to really focus on destigmatizing mental health services, particularly all across healthcare workers. So a big thing moving forward would be about destigmatizing mental health and mental health requirements. Two is about increasing the access in terms of having more trained human resources, but also opening out avenues for lay people providing counseling services, leadership with empathy. So there's a lot of space to be worked on.
Even as the challenges kept on accruing for both the system and the workers, it cannot be contested that the ASHA workers were on the front lines, leading the charge of tracking, tracing, and isolating on the ground. There were also many others who saw this as an opportunity to quickly offer innovative and affordable solutions. While the scope of digitization remains deep across the globe, the solutions for developing countries require a reimagination that relies upon localized and indigenous knowledge, given the vast diversity and complexity of developing nations. The primary healthcare innovations stem across four main areas: system-level determinants, public health center components, services, and outcomes. To dive deeper into the healthcare-related innovations and digitization in the pandemic years, we spoke with Mr. Sanjeev Chhabria from Step One, a non-profit startup that augments government resources with technology, people, and processes to effectively fight against COVID. He spoke to us about what innovation means and how one would explain it in the context of a country like India.
One is the cool, sexy innovation in terms of, drones and the new technology and all of that stuff, right? That's innovative, right? And there's the other innovation, which is not rocket science. Like what we've done is not rocket science, right? We've taken a telephony app, we've taken a CRM app, we've plugged them in together, and we've brought people together saying how to use that, right? Now that is innovation, in my opinion, in terms of being able to solve a very, very complex problem with not necessarily too complicated technical details, right? We need to be able to be flexible and we need to be able to be scaled. So these were the three factors, I think, that played a role in our innovation. Our entire belief system is we're going to get some things right, we're going to get some things wrong, and it's okay to fail, but let's just keep trying, because, the need of the hour is that we've got to deliver something, right? So if we don't get it right, it's okay, we'll iterate and we'll fix things.
To better understand innovation in the healthcare space during a pandemic, we also spoke to Ms. Neeta Joy from ACT Grants, a non-profit coalition created by the Indian startup system to fight the pandemic and drive change. Taking on a funder lens, she threw light on the need for quick responses, ensuring last-mile service delivery and benefits of a volunteer-run organization during the times of crisis.
In terms of challenges, I would say responding to the urgency of the situation was of paramount importance to us. We had to ensure that our deployments reached the end beneficiary on time. And this meant that we had to accelerate a lot of the normal processes and checks and balances that were involved in a typical equipment mission or like a relief activity. And then another challenge was really to ensure that our allocations were equitable and fair. Really, collecting data, working on, calling hospitals, calling district administration, really trying to understand a sense of what's happening on the ground, working very closely with NGOs, who kept us very aware and abreast of the situation on the ground, and also we ensured that our allocation was as data driven as possible.
Both Sanjeev and Neeta emphasize the importance of developing relationships with the government, non-profit organizations, the private sector, and the general public in order to achieve scale and disseminate innovative healthcare products and services. Each of these stakeholders has a role to play in the ecosystem, but it is also necessary to ensure that their roles and resources are optimized and effective.
So first is telemedicine works, right? Second thing is, I don't always need a doctor to be able to care for a patient. There is some amount of caring that can be done by a non-doctor as long as that there is a doctor supervising and guiding those people, right? Monitoring is something that can be done by the patient, can be done by the family. There is a component of patient education which becomes a very, very important aspect of care. Third is that our existing healthcare infrastructure, albeit overburdened or whatever, can be augmented. It's this confluence of the private sector, the government, individual citizens, and I think NGOs as well. Bringing all of these people together yields phenomenal outcomes.
We need to work very closely with the government and really dovetail our initiatives to what government is doing to really, help our initiative achieve scale. So that's been, part of our playbook going forward. And also during this process, we've managed to forge multiple relations with many NGOs who are focused in healthcare. So those also are quite valuable for us as we foray into broader healthcare even beyond COVID from here.
If we look at the response of the stakeholders during the pandemic, there are several case studies from which lessons can be drawn to strengthen and inform future service delivery and healthcare interventions. Here are the top 6 takeaways from research and evidence gathered across various case studies. What is essential, however, is that each stakeholder in the ecosystem recognizes their responsibility and works towards adaptable solutions that promise timely and relevant services to ensure equity and last-mile reach.
Thank you. That was a beautiful video. First time I was looking at it. And summarized the research that you've done so far very well. Namaste and good evening, everyone. Thank you, CoreNet, for this opportunity to meet loved colleagues and new one, both in this panel and outside. Health systems are at the forefront of the pandemic response and themselves are vulnerable to catastrophic changes, which we all experienced. Disruption to supply chain, infrastructure, human resources. Similarly, climate hazards through damage and disruption of critical infrastructure. And this limits the ability to promote and protect the health of the populations they serve and the human resources that are serving them. I'd like to explore with my panelists from their expertise and experience from each of their core areas, because they have very unique perspectives to offer into what they each learned from their recent experiences. Each of my colleagues have very unique perspectives, so I welcome the audience to actively engage. So while we have a session of Q&A for later on, if your questions are very pointed towards a point that one of our panelists is making, I will pause and we will take questions for the panelists. So I'll start with you, Dr. Thelma. You've been at the forefront for citizens' empowerment and voices. So just a question on what is comprehensive primary healthcare and what entities are responsible for rolling out comprehensive primary health strategies? Who's responsible, do you think?
Thank you, Angela, and good evening to all. I think undoubtedly the primary responsibility for comprehensive primary healthcare is the state, which means the government, both at center and state. They have to be play the convening role, as well as they have to be held accountable, because it is a state obligation to ensure the human right of every citizen. And this has been reiterated several times in various documents, and agreements to which the government has signed off onto. The citizens themselves play a very critical role too. So every citizen also has a responsibility as well as a right, to participate constructively wherever, and to take proactive measures, should I say, to protect one's own health in normal times as well as in pandemic times. But as we all have experienced, it is the health system, all said and done, which is the institution, that we as citizens have built over the past 60, 70 years, that I think one had expectations that it would protect citizens at the time of disasters such as a pandemic. And I think we've had a mixed experience during the pandemic, in the sense that, as was shown quite very nicely on the video, that there have been huge challenges. I mean, the frontline workers are, having been on the National Asha Mentoring Group in this early days from 2005 for the first 7 years, and being part of the Jan Swasti Abhiyan and the Global People's Health Movement, which actually brought in very strongly the need for community-based workers, the need for communitization of the health system. We did see that the Ashas played a significant heroic role, but as was very well brought out by our friends from Behan Box and the Asha Sunita ji herself, that they were really at the receiving end of our social hierarchy. So in that sense, I would say CPHC, Comprehensive Primary Healthcare in India, did not meet the expectations, because while there was a huge, all of society approach, no doubt, as has been mentioned, but in that process, we have actually, in a way, exploited these million Ashas who are there, as well as numerous other community-based health workers, including Anganwadi workers, helpers, etc. So maybe I should stop here for a minute.
Just a quick follow-up to that, because you're on a good roll. What would make CPHC more citizen-centric? I know we made a small beginning with NRHM, but why didn't we go forward or, embed it into our systems?
Well, just to take a very quick sort of glimpse through history, since we are a group of researchers in this group, I understand, we have the SOCHARA committee from the late 1930s, the Bhore committee in 1946, the Srivastava committee in 1975, all of whom have raised the issue of community-based health workers who, according to SOCHARA committee, should have received a 9-month-long residential program, and that they should have been rolled out at 1 per 1,000 population. And we're talking, they said it should be done in a matter of 5 years. Now we've 75 years down the line, and we have not we've got ASHAs after a fair amount of struggle, but we have not yet they haven't received this quality and the duration of training which provides them the necessary knowledge base as well as the competencies to meet the challenges that they face when they interact with the community. So the expectations from them are large, but the inputs that are given are really too weak. So in terms of the training, as I said, as well as the remuneration, the social security that is required for them, in terms of even their own personal health, that of their families. So they are considered as volunteers. And even when I was in the National ASHA Mentoring Group, I used to say, why should the poorest women in India be considered as volunteers? Where is the question of fairness and equity when we are talking about this? Look at Iran, look at so many other countries around the world who also have community health workers. This is not a new concept. It's all over the world and it's pretty much researched, And when there is appropriate planning and appropriate career development pathways, appropriate support systems, then their role becomes really what was envisaged in comprehensive primary healthcare for the role of community health workers. Then you need the whole the system that supports them. So they can't be like on their own. And so it becomes a little bit of Maya, you may say, this imaginary, sort of thing. So right now, to make it more citizen-centric, to go beyond the ASHA, to bring in the community and the public, I think the learning, at least from my sort of perspective of the pandemic, I feel the information systems could also have been improved in terms of, it was an unknown to a point. So let's remember that WHO had actually given this advisory to all governments in the late 90s, that there should be pandemic preparedness. Now, I don't think that was actually taken seriously at all. So it was as if SARS and H1N1 and Ebola and all hadn't really affected us in India. We were just waiting and taking it easy, So I think the health system, if it was properly prepared, then the public would have got a better deal. Now, to make it more citizen-centric, the information flow in a situation of uncertainty should have come, I think, from the Ministry of Health, not from the Ministry of Home. I know the Ministry of Health was actually taking a role, but the driving force of the response was the Home Ministry, all the government orders which were coming thick and fast. But, I think the Ministry of Health, we did have people on TV saying things, but I think there was so much else in the infodemic, as we know, on social media, that was creating a lot of scare and misinformation about the pandemic. And that's where the public was getting confused, and so the attacks on ASHA workers or the attacks on healthcare workers came from a public who were not fully informed, about, and they were not consulted as equal participants. So I think the public are equal. In fact, they're the owners of the health system. Let's remember that the financing of the health systems comes from taxpayers' money. They are the owners of the public health system, And when you think of it, even the private health system, where did the money come from? It's from those who use the services, So the owners are the people who use the services.
Right.
Their voice needs to be, I think, there in planning as well as in feedback loops.
Thank you. Thanks so much, Dr. Thelma. Dr. Saiyed, I'm going to move over to you. I've been following all your work at CCAMP and low-cost affordable diagnostics. So share a little bit about your experience of what happened during COVID and what is the role of technology in strengthening the comprehensive primary health care.
No, thank you. Thank you, Dr. Angela, and thank you for having me here. It's a pleasure. I would say that I think if I take a leaf out of what Dr. Thelma said, which I strongly believe in, the healthcare, in general is a right to a citizen in a way, and primary healthcare more so. And when the times come when in situations like pandemic and so on, I think the role of healthcare becomes such more critical, as we just saw in last 2 years and so on. I think during this times, we realize that there are ways and means possibly we can make the system much more, I would say, efficient by building innovations and technologies and innovation in the play. So one, we can talk about healthcare system from a perspective of system, and then we can say how new innovations and new technologies can actually enable the system to do more, while the system itself absolutely should be on its way to improve and do both. So I think if I may take the angle from a perspective of innovations, as you rightly said, there were many things which happened in the last 2 years, starting from perspective of prevention of the spread of infection to testing to treatment to doing many things. I think there were many innovations and efforts that we did. And at CCAM in Bangalore, we did a lot of work in collaboration with many organizations, including with PATH, where we in a way attempted to identify innovations which were in a shape and form ready to go in the field and be deployed and make a change on the ground. And we few of the work that we did, let's say to begin with, you talked about some work in the diagnostics. So let me put it this way. I think we began in COVID-19 situation where we did not have our own COVID-19 diagnostic capability, manufacturing here. And our needs for a country of 1.3 billion people, our need was really humongous, because as WHO mantra went, test, test, test. There was a reason behind the test. The test was to first of all, identify individuals who are affected, isolate them so they don't carry on the cycle. So there was an isolation. Test early so the affected people do not go into severity and show symptoms, so that you actually take them directly into ICUs, and that's very difficult to bring them back. So there was a reason to test. And our situation was that we didn't have enough kits to test. So the foundation of fighting the pandemic was not there with us. At that time, we actually envisaged that can we now look at our own capabilities with MSMEs, with academic developers and many more, to see if collectively we create a platform which can have an ambitious target of building this capacity in India for not today, but for future as well. So we put together this program, which we call it as indigenization of diagnostics, with many partners in it. And that got supported by Rockefeller Foundation, very, very kind of them to come in at a very crucial time, because we are not able to actually find support for that. With many center of excellences at academic institutes and over 150 MSME partners, within a year, our vision was to bring in capacity to build 1 million tests per day, RT-PCR per day. And I'm very happy to share with you all that we have achieved this almost 6 months back. And we have the ability to as well produce it and even given outside India if the sanctions are not there to be provided to Africa countries and many more. So we not only became self-reliant, but we became capable to even export it in such a 1 year time. And so we brought in the accessibility. Another thing we brought in here is actually affordability. When we began, the test was costing around 4,500, if you all remember. Through the efforts of building indigenous Make in India kits, which are as good as the others, right now the RT-PCR test reagents are costing less than 50 rupees. And the test possibly is costing 250 rupees, 200, 250 rupees with all delivery. This is almost 20 times drop of the cost. And that actually is very important, because this is where the testing has become efficient in rural areas, in the tier 2 cities, tier 3 cities, which were very important. And if we are seeing another surge, which is in front of us, I think this will remain as important. If I may stop for this point now and say, but this platform has now a long-term capability. What we have done, Dr. Angela, very important, is not only responded for this time, but we have built a long-term capacity in India, which can now respond to a future pandemics of infectious disease, because this MSMEs are now working at the same level of quality and scale that we were not, which are international, but we are not there before pandemic. So I think that is a very good outcome that has happened out of it. accessibility and affordability within a year at that level was definitely a major outcome and has happened because of the convergent platform, not only at CCAM, but convergent platform which was put together and supported by Rockefeller Foundation. I'll stop here for now and build on other things later on. Thank you.
Thanks, Dr. Saiyed. That was a comprehensive story of what happened and where you're going with this. Let's hope we don't have another different pandemic again. But would you say that the regulations, the regulatory approvals and all of those systems also caught up with your producing of indigenous diagnostics? So would we be just as fast if there is another surge?
Yeah, no, absolutely. So thank you for that point as well. And I also hope that we don't see pandemics, but preparedness is a preparedness. We have to prepare for the worst. So I think that is important. So coming to the regulatory component, I think we have definitely improved. We have definitely improved where the dialogue with the regulatory bodies have happened. The much more clarity has come in terms of what kind of quality is required. This can still be better. This can get better. There are many components which can get better. And I hope that the rigor that we showed during the pandemic time doesn't fall off. I think that rigor was very, very good, which we saw that we all are capable of doing and moving at warp speed. But that should not go back to again, the same turtle slowness that without the pandemic situation. I think that is something we can keep on. The passion, the goal, the components that we want to do together in terms of change on the ground, if it remains same, I'm sure that we will be more than capable of building a change that we all want together.
Thanks, Dr. Saiyed. Mohammad Ameel, you've heard about the role of the public sector. Dr. Thelma spoke so eloquently about the role of civil society and citizens' voices. And now we just heard from Dr. Saiyed about low-cost diagnostics. So $1 million question to you, or maybe $1 billion question to you. What is the role of technology in comprehensive primary care?
No, thanks, Angela, for your question. And it's a pleasure and honor to be on this panel with such eminent people. I think all of us have mutual regards and respect for the great work that all of you do. I'm glad. And in fact, after I respond to your question, Angela, I'd just like to add what just Dr. Taslim said. We interact offline as well, but yeah, to that point as well. But to your question, Angela, in the PHC landscape, there are many challenges and there's a severe shortage of manpower, which is also overburdened with some clinical work, some administrative work. There are broken supply chain, which leads to frequent stockouts of essential drugs and consumables, which does not favor a continued delivery of service. There's a weak referral management system which fails to ensure timely treatment to identified patients, which leaves them disillusioned with the public healthcare system and further erodes their trust in it. So the vast amount of data that is being captured in public health system too suffers from poor quality and unadhered timelines. The soiled system of data capturing, reporting render the information unusable to carry out any analysis or generate any evidence for planning and policy making. Finally, the unfavorable attitude within the community towards preventive care, the tendency to delay the approaching the doctor due to many socioeconomic and physiological barrier is another demand side barrier. So the recent spurt in technological innovations, which Dr. Taslim very rightly mentioned, has significant contribution to the health sector, especially provision of CPHC. Technology, as we know, can be a great enabler for service delivery, especially in low resource settings, some of the challenges that I mentioned. So technology is not always the high-end technology and innovations. It's actually more required in places which are resource constrained. So we need to be very, very aware of that. So it can help create an integrated health system that puts the patients at the center of solutions to deliver accessible, comprehensive, high quality and affordable care. So the emergence of smaller and cost-effective devices in the recent times has, for example, led to rise of self-care, ranging from measuring sugar to screening for viruses like HIV, HPV at the convenience of the home or closer to the community. Devices, for example, for screening and diagnostics is now more compact, packaging multiple services into single device. So 16 to 20 tests within 5 minutes have become a norm in emerging point of care diagnostics, addressing challenges including burden of service providers, time and need to collect and transport samples at the primary healthcare level. Even in the communication revolution and emergence of technologies, if you see, access to specialist counsel has become much easier than ever. Telemedicine proved to be a boom during this COVID when many feared going to hospital but were in the urgent need of medical attention. Even when the pandemic wave had got down, government had not put its guard down. Sanjeevani initiative of the government proved to be a major advantage during post-COVID as well. And we saw some landmark achievements during the Health and Wellness Center Day this year. So integration of POC devices with telemedicine can actually revolutionize the PHC ecosystem. I'm just talking about one specific example here, and then can also reduce hardship for many, especially in remote areas, who often have to travel long distances at the cost of their daily wages to seek such consultations. Uniform and unified health data will also help better utilize data for decision making by making efficient use of such tools and predictive analysis. So just one example, if you are able to actually provide the 3Ds, the doctor consultation, the diagnostics and the drug at the same time. So you are actually giving a complete package to the patient in their first visit. So they do not have to come back for most of the time for their another day of wage loss, because what we've seen, if you do someone's X-ray and ask them to collect the report or the film the next day, they usually do not turn out even if that X-ray is for free. So we need to see how their walk-in time and the reporting time, they get a complete package in the first visit. And I think at the primary healthcare level, it's quite possible, because you're not asking for very high-end tests, or you're not asking for very specialized consultation, or you're not asking for very high-end drugs. So that's there. And even for chronic patients, even if they are require some care, let's say in cancer care or some other non-communicable diseases, closer to the community, if you can ensure their diagnostics or drugs be provided to them closer to their home, I think it would be a big revolution, and technology in all this will have to play an important role. I'll pause here for now. Thanks.
Thanks, Mohammad Ameel. That was really good. It was very, very comprehensive. So lots to think about and talk about. I will now move to you, Madhavi. You must have been, like most of us, super busy during the waves. And I hope that your team was resilient to push through it. So tell us a bit about what you saw from the field, particularly from health workers, and how do we go forward from there? How do we build in the resilience?
Okay, all right. Before I begin answering the question, though, I'm going to give a brief background of the Thrive project that I'll be referencing for its learnings and findings. So over the past 6 months, the Thrive team at Sangath Bhopal has been trying to study team resilience trainings as an effective intervention for health service providers at healthcare centers to prevent burnout and reduce levels of stress, anxiety, and depression, especially in the context of the pandemic. To understand the mental health impact of the pandemic in particular, but also the mental health impact of being a part of the health system workforce in general, we had spoken to academicians, public health professionals, psychologists, doctors, nursing superintendents, We also spoke to ASHA managers and social workers, and all of our advisors also had lived experience of mental health concerns. And discussions with our advisors actually painted a very bleak picture of the overburdened, understaffed, and under-resourced healthcare system in India, with an inadequate focus on the mental health of its service personnel. And we also heard a lot about a work culture which was very heavily steeped in power dynamics and hierarchical structures. Our advisors also reported gross inequalities in terms of working conditions, in terms of professional respect, in terms of availability of resources, facilities, and with most public hospitals being under-resourced and overburdened, the pandemic only aggravated these pre-existing conditions. And well, of course, this situation has very far-reaching mental health impacts. Health service providers who are frontline workers and were involved in direct patient care during the pandemic, they reported experiencing stress, anxiety, burnout, depression. They reported feelings of loneliness due to the pandemic, creating a massively isolating work environment for them, and with long working hours keeping them away from their families, their social lives. But also, I feel at this point it is important to highlight that these experiences are not restricted to the pandemic phase only, because according to our advisors, the pre-existing hierarchical structures in the healthcare settings have always made them face discrimination and have made them feel helpless and frustrated, and they have felt that they don't have adequate support from their leaders. And all of these feelings and experiences are linked with anxiety, depression, and burnout. And if we think of the most important question of all, that what mental health support services actually exist for these health service providers, the public health professionals we spoke to actually stated that not only is mental health support and training such an alien concept in healthcare settings, but they also felt that the system, and I'm quoting verbatim here, they said that the system is built to suppress and squash their humanity and self-esteem. They said that the system strongly discourages any self-disclosure about their mental health concerns, and it humiliates them if they speak up and seek support for their mental health issues. Because there is no focus on mental health on a systemic, on an organizational level, the team leaders who actually do put in the effort to address the mental health concerns of their juniors and team members are called weak leaders. And thus, most of the consultants we spoke to said that they don't at all speak about their distress and mental health concerns to anyone, to the team members, to the peers, not at all, because of course, stigma, lack of understanding, and the severe lack of safe and non-judgmental spaces for them. And yeah, so I'll stop here and I'll wait for everyone to help everyone think that very bleak portrayal of the mental health crisis situation in India, but it's true.
Oh, thanks. No, that's a good. I don't want to say that's a good picture, but I did already. As in, but that's a good bird's eye view of what's going on. And I've seen and heard a lot of what you're talking about. So let's move forward, right? So what might a country do to address a lot of these issues?
Okay, all right. So while through our research study, we don't really have insights on what our country at large can do on a macro level, we do have insights on a micro scale about the practices organizations can implement to make their teams more resilient and to reduce their levels of burnout, stress, anxiety, and depression. And also the traits that team leaders in these healthcare settings can imbibe in their way of working. So for instance, our advisors who are also team members opined that having very strong lines of honest and non-judgmental communication about the needs and problems is essential for their teams to be resilient and feel motivated. For instance, team members having the freedom to openly talk about their roadblocks, their mistakes, without having a fear of being penalized is very important to effective team functioning, and especially in healthcare settings. Beyond that, health service providers, especially those at the front line and working in crisis situations where their lives are in danger, They just express the simple need that we want to feel protected. We want to feel protected from untoward situations, from abuse, from violence. When we are out there putting our lives in danger, we want to feel that our families will be taken care of. And these simple practices of organizational empathy, what we can say, they actually go a long way in reducing feelings of uncertainty, fear, and stress. And this enhances morale massively, which is an essential and attribute, I believe, for healthcare teams who are working so tirelessly, for the public good. Beyond that, our advisors also mentioned that, of course, like we have spoken about before in this session, organizations have to ensure that psychosocial support services are not only available but readily accessible for those people who are experiencing mental health concerns. And also that team leaders should ensure regular debriefing sessions after adverse situations so that team members can collectively cope, learn from what happened, and move forward. Another thing which was very important to the health service providers we spoke to was that they mentioned that they want to be very intensively involved in the decision making process about any policy which affects their well-being and their work. Thus, all health service providers, irrespective of their position in the health system hierarchy, should be engaged in decisions if these decisions involve them or impact them. And they should form a part of a wider staff support ecosystem. And well, I would like to end by saying that one important thing we learned from our advisors is that healthcare resilience is an ongoing dynamic process that can't just be focused on disasters or pandemics. And given the fact that healthcare is such a high stakes, high pressure environment that is prone to be so physically and emotionally taxing even without a pandemic, building resilience on an individual level, a team level, organizational level, system level is something which needs to be done consistently as a way of working. And like in this discussion today, for instance, we heard from so many different areas of India's public health structure. We spoke about primary healthcare. We spoke about community resources. We spoke about innovation. We spoke about diagnostics. And if there is anything which our team has learned from our study of teams, it is that resilient individuals do not build a resilient team. And in the same way, it is not enough for each of these different segments and areas of our health system to be resilient in themselves. But if we want to ensure health system resilience as a whole, we need to work together cohesively and communicate with these different segments and areas, coordinate, share knowledge, share resources, and well, at the end of the day, have a common goal, a common vision. And yes, that's all. Thank you so much, Dr. Chaudhuri.
Thanks, Madhavi. Let me see if we have any questions. That's great. Sanjeev Chabria says, we all speak about primary healthcare, including physical, mental, and social health, yet medical education has historically focused on the medical curriculum. We saw this magnified so much during the pandemic. What are the panel's thoughts about medical education shifting in this direction? Can I see all my panelists? Yes. Dr. Thelma, you want to take this question?
Sure. I think actually this is an extremely important question for the future. And we have to learn from the past in the sense that having been a medical educator in the first 10 years of my life, that we actually are not trained adequately in the factors that were very eloquently articulated by Madhavi. We are not trained in psychosocial dimensions of human beings. We are trained to diagnose and treat. We create this biomedical model where the psychosocial cultural dimensions are sort of left out. They're considered like less important, but they're crucial as we've learned. So the reform of medical education, which is a work in progress. I mean, there have been efforts now, even with this competency-based curriculum that's currently, from 2018 onwards. So that's a step in the positive direction. But I think the the training of the faculty is where we need to have much more effort, because faculty are just expected to be able to do all this when they've never had a training on this or experience. And this hierarchy, this structural hierarchy that every medical student, and let's talk about all health science categories, that they grow up in this hierarchy. Just to give you an example, that people sitting in a common college bus with multidisciplinary health team members, only the postgraduates of medical sciences sit in the front, the others middle row, and the paramedic right at the back. Now that's a sign of the sort of hierarchy, and it really adversely affects a person's psyche. And so the attitudes that develop through that 3.5, 4.5, 5.5 year long process is a process of socialization, which is learned, unfortunately, and it reinforces the hierarchy in our broader social system. So we have to unlearn many things in a systematic manner through curriculum change, through faculty training programs, through feedback loops. The pressure that undergraduates and postgraduates go through in all the, all the streams of health sciences is quite phenomenal. And during the pandemic, we know that many of the students who were pushed into playing roles which they were not really prepared for, including dealing with death, giving bad news to relatives, working with they didn't have the necessary support system. So I think medical education is really at the root of a lot of what we see. And the processes of commercialization and this rapid growth, I don't think are in the right direction. We have to be far more thoughtful, and we have to dialogue with with the student community, just as Madhavi and team have done, in the context of the health system. If you take the student community as a community, they have a lot to say.
Thank you, Dr. Thelma. We have another question. This is about the private sector. The private sector played a vital role in the COVID response. What could be some innovative PPP models to strengthen the health system? Dr. Saiyed, I pass this question to you. You mentioned a lot about MSMEs in your talk, so I'm sure you have something up your sleeve.
Yeah, no, absolutely. I think it's a very good question, I think, and something that we should look at as a forward-looking models to see how the health systems could be, improved upon. I think what we saw in the times last 2 years is the more or less a cause and people coming together across different sectors and working towards that cause, be it the public sector, private sector, the young MSMEs and so on. And it has happened wherever it has happened well. I think let's look at those. And those models more or less tell us that it was built around, if we talk about healthcare system, it was somewhere, and I will feel very strongly about somewhere it was also built around technologies and innovations. The technologies and innovations which were possibly, built locally, we needed somebody to get a right to take it to the healthcare system, deploy them, and make it largely available, because this technology, which are built locally, understand the local infrastructure, local settings, which are not necessarily parachute landing of innovations or technologies, which we struggle with. It works very well in tertiary care hospitals. It doesn't work. The same technology may not work because it's a complete chalk and cheese in terms of healthcare infrastructure we're talking about. So those are technologies built from here, affordable. I always say that we are building medical devices and medical innovations from a side view mirror of affordability always, because that's where we are growing up. That's the system. So a lot of technologies that are built from here are around that. So a model that we need to do is that how private sectors, which are developing this, the young startups, young innovators, we are building on this, the big hospitals, which are actually either private or public, can we partner together and actually incentivize of using these innovations, if on their merit, basis of their merit, nothing else, basis on their merit, and see if we can change the way the adoption of this would happen. I'll give you a very quick example. I'm aware of the fact of the time. I'll give a very quick example. If we were to do something in terms of screening for expecting mothers in rural settings, right now it is very difficult to get them to a district hospital where ultrasounds can be done so that we can figure out the fetal movement, the fetal heart rate, if everything is going okay. Can we have a small device, which is possible now, which is nothing but a small, 1 by 1, like 2 by 2 centimeter inches big, which is actually a device which is developed now right here with CCAM and many other places, which can be put together and which can actually give you in the hands of healthcare worker, be it ASHA, anybody, and screen everyone in a rural setting every 15 days. And the data on AI basis can tell you where the fetal movement is actually not appropriate. Put them as a flagged cases and take them to gynacs for a follow-up. Now, this is very, very important, but this is changing the way things have to work. And this is where the pilots could be built for expecting mothers screening setup, which can be taken together. It can be done every 15 days for every rural setup. By doing this, the data will go on cloud. It is actually going to tell us where the heartbeats are an issue immediately, where the fetal movements are an issue, and once flagged, can be taken to district hospital for a check so that we can intervene immediately in terms of time, and it is not too late in the game. And these are the models where the innovations, the MSMEs, the setup, the hospital settings can come together and build it. And I think we have to accept these models. It cannot be conventional, a procurement model which goes together. We have to change the models where innovations can come together and do it. I strongly believe this was a very simple example, but many such innovations are there. If we actually bring them to the fore, we have a possibility of taking care of many issues that currently the system is plagued with, be it infrastructure issues of large equipment, electricity, be it specialists. We do not need gynecologists to look at this data. AI can look at this. Many other issues can be taken up, and healthcare system can be built strongly using this technology as screening, not replacing doctors, but screening before doctors can come in. Thank you.
Thanks, Saiyed. Ameel, did you want to chime in here as well?
Sorry, I was having issues unmuting myself. I think just to what Dr. Saiyed just mentioned, I think it's the person who's developing this can be the next Bill Gates, I'm sure, because this is a big problem, ensuring antenatal checkups, and not Bill Gates from perspective of money, but the impact his technology has had. So because antenatal checkups in the community has been one of the biggest challenges, not only because access to ultrasound has been restricted because of PCP and DT Act. None other than radiologists or gynecologists or medical officers trained in center of repute can use it. You can't bring this below a block level, and block level is also a dream for most of us. So a device like this is certainly going to be helpful. And regarding the role of the private sector, certainly a good mention by Dr. Taslim, but I'm sure there's a lot of work to be done still in order to make the best use and leverage their capacities, and in a way that their role is non-conflicted in the overall environment is very important, especially from the service provider's perspective. In terms of provider, in terms of product perspective, for example, all these newer technologies, innovations which came up during the pandemic, some of them were mentioned in the discussion on genome sequencing, on RT-PCRs, but also on the, for example, pressure swing adsorption machines for oxygen. All these were a contribution by the private sector. Majorly, the government did play a role, but that was quite limited. So I think, yes, there has been a great support, but a lot of ground needs to be covered. Over from my side. Thanks.
Thank you. Dr. Thelma, I think the next question is for you. And this is about the issue of ASHAs, which is rife with inequality, inequity, caste and class discrimination. When and how might this view change in terms of how they interact with community and as well as the system.
Yes, thanks. I do feel that change is possible, and in more egalitarian, fair and rights-based approach. But it will require constant pressure and constant effort. It is a struggle, and it's not going to happen by itself. Let's not expect that some fairy godmother is going to come and change the whole thing. So I think systematic planning, where there has to be costing and detailed planning of the role of all the requirements of ASHAs, including their training, ongoing capacity building, remunerations, all of that has to be done with in a way like the International Labour Organization norms for any healthcare worker, particularly a community-based healthcare worker. And if we don't do our financing planning and the HRH, the Human Resource for Health planning, we will not be able to rectify the wrong that is there currently. So right now there's a glaring inequity that has been rightly mentioned. And I don't think that we need to start work on that like today, And I think research can also play an important role. So the video, and there are new forms of research. The research methodologies itself need to be looked at, and how they are disseminated and fed into policy changes at not just at the national level, but at the local level. So policy doesn't only change at the top, so it can happen at a district, sub-district level, at the state level. So this feedback, so if the researchers also engage with the administration as well as with the community. So if we get used to these interdisciplinary research teams, functioning, and then engaging with the broader community, taking it forward. There have been many experiences of this within India itself, So then I think the role of the ASHAs can change. So the ASHA voice in this process is crucial. ASHAs will have to be part of the design of the research process, the design of the planning process, and the feedback loops. They have the most experience in some of this, and they as Madhavi and team found that they may not share everything. We do have, but it's not, if one listens and has the culture and the ability to listen and dialogue, it's an ability, it's a skill to be able to listen and dialogue, which actually presently is missing in the health system, even at the individual level, but also at, at a system level. Thanks.
And that also ties back to what are we teaching in medical education, because we're taught to look at some of body parts, but not the human in and of itself, and certainly not taught to care for ourselves in the process. If you don't care about people who work in health, how can we care about the health of the people? Feel like a good point.
I think the point also, just one sentence of, having the skill for community engagement as important as the skill of taking a blood pressure. Now, I know you may have nowadays machines who automatically take the blood pressure. It's not going to be that easy to get a machine to immediately, maybe AI can do it.
Yeah.
Hence the pulse of the community, their anger at water supply coming at 2 a.m. once in a week or once in 3-4 days, or not having electrical supply near the toilets, not having access. Those are the determinants of health which affect ASHAs too. So I think that's where we need to also work.
Absolutely. I love this last question. I ask myself this often, and I think it's great that all of us here must have had some challenges in explaining our work. If you work in health and you're not the doctor, then what the hell do you do? And so the COVID pandemic has given at least me some opportunity to be able to explain what it is that I do. And Madhavi is nodding her head quite vigorously. I wonder, how do we make hay while the sun shines? How do we take the momentum and say, hey, this is what is public health. It needs all of us. It needs all of these different expertise. How do we keep the momentum on? And thanks, Babita, for the lovely question.
Should I
Yeah, go for it. Yeah.
All right. So how do we keep the momentum on? I'll answer this question in two parts. I'll first talk about something Dr. Saiyed and Dr. Mohammad have spoken about the field of digitization, innovation, having healthcare provided at a mass scale. And I want to bring about the topic that mental health care and technology, the intersection of mental health care and technology and artificial intelligence, is actually a field which has, I believe, not only far-reaching impact in ensuring that mental health care reaches the masses, but also in terms of effectiveness. The research I have read about the sort of therapeutic alliance which can be built between an artificial intelligence chatbot and a user, and the therapeutic alliance which can be built between an actual human psychotherapist and a person. These two rates are comparable. The mean difference between them is not significant, and that is insane to me. Given the fact that vast swaths of India's population now have access to smartphones, the sort of public health impact having an application which can leverage the power of technology and AI to actually service mental health needs to the masses, I believe that's absolutely massive, and the potential of that is massive. And I also want to touch upon something which Dr. Narayan said about medical education, and she spoke about, and it's true, medical education. I have also heard a lot about medical education and how for the longest time it's been homophobic and transphobic, and how marginalized communities haven't found a voice, if within these textbooks. And even non-biomedical fields like psychology were also for the longest time propagating that LGBTQIA communities are suffering from mental disorders. But I do have hope that this point of view is changing and changing rapidly. And that is primarily because of the increased advocacy from these communities in the past 20, 30 years, especially in India. We also spoke in the beginning of this session about how empowering communities is so important. And I think social sector organizations like the Mariwala Health Initiative, they are doing really good work in empowering marginalized communities and helping them become advocates in their own space. And even within Sangath, we are conducting a project called Transcare, and the Transcare team is actually working with public health professionals and colleges in trying to revolutionize medical curriculum as a whole and making them more queer affirmative, so to say. So I do have hope. I do believe that we've made a lot of progress in the past 10-15 years, and yes, I have hope for the next 15 years to go.
Cheers, Madhavi. When I asked this question, I saw sort of a sparkle in your eye, Dr. Saiyed. So do you want to comment on how do we maintain the momentum of this expansive view of what public health requires?
No, absolutely. I'll try to be brief, but I think I feel, as you rightly use the word, expansive, where it's very broad, very complex, and I think I think 2 points I'll make very quickly. We all have to possibly address it from different angles of strength that we have to the questions that we can. I think it's collectively from different sides the system would come at. It would not be a one key for so much dynamic puzzle that this is. So we all have to come from different sides, be it, biomedical health issue or a non-biomedical, but mental health issue and many other aspects of it. So we all have to do it, and we all possibly in this panel and otherwise as well, there are different expertise which can be glued in, but we cannot let it go. Health has become such an important component. So we have to keep the momentum, we have to keep the temperament, we have to keep it going and push and nudge people to keep it. That's one. Second, very quickly, if I may say, I think broadly, many times the problems are unsolved because the questions, we think that questions are well articulated already and there is no answer. We have to re-articulate questions again and again and put them to the table and say, by the way, this is the final problem. Come and solve it. I have done the re-articulation of problem. Let's invite people who are smarter outside. Come and solve it. I think that exposure of problems is sometimes very important, and we may want to do it wherever, whichever angle we are working with, because we think that there's some problem with some health workers somewhere, but have we actually articulated it to the T and I's and then put it out and see if somebody can think that this can be resolved? I think those two things I wanted to share with you. Thank you.
Thanks, Dr. Saiyed. I hear that Sanjeev Chabria from Step 1 is here with us. We heard from him briefly during the playing of the video. Are you here with us? Hi, Sanjeev.
Hi, good evening. Good to see all of you guys. So, and it was, of course, very, very, very thought-provoking, the entire conversations that have been happening all along. I was a little distracted intermittently, but I caught most of what you're saying, right? So, having lived through this pandemic, a part of me wonders, we've been in a state of crisis for decades in this country. Whether you look at physical health, whether you look at mental health, the whole gamut. I don't think anybody over here needs any further elaboration on that, right? And while the pandemic was definitely a crisis, there's been a lot of awakening that happened as a result of the crisis. But the reality is that these crises have been there for eons. How many people die of tuberculosis every year? How many people die of suicide every year? How many people die for a whole bunch of reasons every year? How many deaths can we prevent, right? And I'm just hoping that somehow there is momentum that sustains at the end of this pandemic. I'm already starting to get a little bit of apprehensive because I'm seeing people's attitude towards not wearing a mask and so on and so forth. So I'm just thinking how the medical fraternity, how the public healthcare policy workers and so on and so forth are going to continue to kind of focus on that, right? And I think, the one other thing I've been very fortunate is that I've worked in several countries across the world in several healthcare environments. And I see a huge distinction between working in a healthcare system that is socialized and not socialized. Everything in health is a priority. There is no hierarchy in team members. Everybody is a contributor. There is a concept of a transdisciplinary approach by me in which, it's not so role-based. And I'm keeping my fingers crossed that in our lifetimes, we'll get to see some movement in that direction. If there's anything we at Step 1 can do to contribute, if there's any collaboration, we are very, very open and receptive to doing anything we can in terms of using our platform. I'd love to be able to see some massive paradigm shifts happen, like we saw during the pandemic, beyond the pandemic. Thank you. Great to meet all of you guys.
I think the project Step 1 has shined a light on how the differently qualified people can actually do similar jobs and how a lot of task shifting and team-based care can actually happen. And I'm hoping that people will take that and shine a light on how that was quickly scrambled together, but then now we can actually do it in a systematic way. So I think that basically answers my question on keeping the momentum in this expansive view on public health. So I'm going to do one round robin wrap up on what is your 1 or 2 key takeaways that would make our system a little bit more resilient. So in the face of the same adversity or similar adversity, how can our health system do better? And I'm going to start with you, Ameel.
Thanks for the question. I think I'll just carry the momentum of what we were discussing. We saw during the pandemic, every level of healthcare facility got exposed to something new, be it newer technology, be it newer processes of doing things, be it newer knowledge, be it anything. We need to ensure how do we sustain these investments, else it's going to become a white elephant in the future. And so, for example, the there have been investments in big oxygen generation plants, which have been such a big challenge in the past, how do we ensure that its operations and maintenance are sustained? It's going to be a big thing. We've invested so much on, say, genome sequencing. We've invested so much on surveillance systems. But unless we have a plan for good operations, maintenance of it, sustenance of it, these are going to become, as I said, white elephants, and we need to take care of them. And as I said, these are some of the facilities. These are the first time that these have been exposed to, so they do not actually know how to use it beyond the pandemic. So we need to have those plans in mind. Thanks.
Madhavi?
So I will touch upon what I've already spoken about briefly, that I believe to carry the momentum forward, we need to empower health service providers to actively participate in mental health policy at every level, within their teams, within their organizations, because I do firmly believe that a revolution in the way mental health is looked at in healthcare settings is underway. And it is being led by these very same health service providers who are lived experience advocates and who are sort of trying to change the system from within by changing the way they're communicating with their peers, with their teams, and by driving an organic change in the culture and mindset of the health system in India, by fighting against stigma, by openly talking about their own mental health challenges, and by trying to create non-judgmental safe spaces where they work. So again, I believe that yes, having an active role for lived experience advocates in mental health policy at every level of the health system, I think is very important to ensure that this momentum goes forward.
Thanks, Madhavi. And I love your choice of words, lived experience advocates. I think I might use that moving on. Dr. Saiyed, your thoughts?
No, I think I would say, I think simply, it would be fantastic to possibly see if there are, a collated few points that could be actually from the best practitioners which have happened during this time, if those can come together and those can be provided as a white paper to different state, district level, state level, and national level, and see if the administrators at whatever level can actually take a spot at it and try to respond, and those components can be discussed further, because I think it's very important to now collate it. Whatever has worked, best practices have to be collated and say that this changes need to be done. I don't know, we have not done a collation of sort. We have spoken about it in different circumstances and aspects. Possibly a good idea to possibly collate completely different exercises, different initiatives, different efforts which have happened, and see if those come out with top 50 efforts and one-liner gems of those, the recipe of those, and see how would that look like, and see that could help in a larger effort.
Thank you, Dr. Saiyed. Dr. Thelma?
Thanks, Angela. I also believe in a strength-based approach, and an evidence-based approach. So I think looking at the overview of the health system, and we're talking of resilience for the entire 1.3 billion population, where every citizen matters. So I think if we take an evidence-based feedback about what is happening, and also look at the root cause analysis of the determinants of health. You see, you mentioned in passing climate change in the beginning, and I feel that's critically important, and it is linked to the pandemic, as most of us know, and I don't see that sort of, there's a different response to climate change and a different response to the pandemic, and that speaks about who we are as human beings. And it's easier to grasp it and respond to something which is more immediate than something that's very large and seems to be beyond our ability. But if we do not address issues of climate change and all the other broad determinants, we're not going to improve health. We may improve health care, but they're not the same thing. So while a person with diarrhea or undernutrition gets access to good care, they go back to the same environment they come from. Our team works in Madhya Pradesh, and through the NRHM, NHM, we've got extensive feedback from across the country. Let's not live in la la land. I think as researchers, we're all critical thinkers too, and we are not hesitant to face reality, look at data. We have to use a data-driven approach. The lack of access to essential healthcare for so many other conditions, tuberculosis included, but all the non-communicable diseases, the rehab care that was needed for persons with disability took a big hit during the pandemic, and that people lost lives and lost, so I think we have to look at it from a broader lens. Maybe my gray hair makes me, I'm optimistic, and I like this idea of a broader paradigm shift. We have worked with Step 1, by the way, and some of our younger team members, and it was really quite energizing and very useful. And we reached out to we communitized it by reaching out to community animators through NGOs in Bangalore, etc. And I think that sort of paradigm shift is possible using technology. I'm all for that. So I do see that in 10 years, we should hold ourselves accountable.
Absolutely.
The change. At this point, we can't blame globalization, colonialism, or anything else. We have to take the responsibility, ourselves.
Thanks, Thelma. I see Sanjeev jumping to acknowledge and share. Please go ahead.
No, I mean, I completely agree. There's 2 points, Dr. Thelma, that you said. Number one, we've got to take accountability. And I think, blaming colonialism or anything else is really not going to be of any help at all. And I think the other thing that you touched upon, which is very, very important going forward, is using evidence-based practices to deliver whatever care is being delivered anywhere, right? We saw this during the pandemic as well, when there were all these, these prescriptions with ivermectin and azithromycin and a whole suite of antibiotics that were floating around that had no evidence, but these things were being widely circulated, right? So we worked closely with the government of Karnataka. As soon as we presented them with guidelines based on evidence and they signed off on it, that is what got delivered consistently for every citizen that came to us and knocked on our door, right? So I think the entire concept of evidence-based medicine and accountability are somewhat related to each other. And in countries where countries where there's socialized medicine, the outcomes are part of the entire accountability process that is there. And I don't see that infrastructure currently existing, in India.
Thank you. And I have my 3 points to my own question, so let me try and share that as well. One of the things that I thought would be great to have while we're going through this pandemic and, slightly anxious about the next wave, if there is one, and the scourges. And yes, climate change is my favorite topic at the moment, is actually building of public health capacity across non-health sectors. If our administrators had public health perspective, I'm not even talking about skills and knowledge, there's plenty to go around, not enough, but I'm not asking to transform that, but just having a public health perspective, because they are public administrators and everyone needs to have a public health perspective, and beyond clinical or beyond a cardiologist in scrubs saying something, it has to be beyond that, right? And so I think for resilience building, we do need more administrators and people in public places to have a public health, population health perspective, particularly that context about where equity contexts, because we had a lot of solutions that were meant for rich and middle class people. When COVID rolled out, the people who didn't have Aadhaar cards or phone or smartphone numbers were left out. So just that perspective building, I think would be very useful for resilience building. And I touched upon education itself. I think now youngsters are coming up and saying, hey, we want to do public health. But in our country, to do public health, you can't be an engineer or an architect or a designer or someone who loves drawing or a sociologist. You have to have clinical sciences. That, I think, we're doing a great disservice to the field of public health itself. It's not so the case in many universities abroad, but in our country, we still look at it with very, very narrow lenses. And how might we try to expand that lens when it comes to the public health education in our country? And then thirdly, again, to do with education, but more so perspective building, is that we have so much to share. How does it become digestible, consumable, in the right language, in the right forum, and using the right style and language that can go to the last mile? We're researchers, we're talking amongst ourselves, maybe it floats around to the next level, but so many of these little pearls of wisdom from the bottom to the top and backwards and around us, how do we do that much better? And I think then we can really be able to help ourselves. Climate change is right here. To me, that's not even a hidden pandemic. I've moved to India, to Bangalore in 1991. We barely switched on our fans, forget about air cons, and now we have air cons in all of our rooms in our apartment. That is very scary. And that's just in a short span of less than 20 years. And so I'm petrified about what my child and her children, if she has any, are going to face. And the fact that we are so responsible for it. And the health system also emits greenhouse gases. So how do we actually, that's right, so we're trying to help people, but we're not really helping ourselves. So how do we all green everything that we do and mainstream that is actually one of the biggest levers of public health that I can think of. So thank you so much for having me and being part of this panel. Thanks to the audience for being with us for over an hour and a half. And Cornet, back to you.
Thank you so much, Dr. Chaudhuri, and to all the panelists. I think this has been such an insightful conversation, especially I'm sure for people working in the healthcare space, whether it's in India or in any other low middle income country. And I'm personally also leaving with a lot of reflections on several topics that we've already touched upon through the discussion. And like Dr. Saiyed and Dr. Narayan said towards the end, there are various best practices to learn from, and it is also time to collate these in an evidence-based manner. And as a part of the CoreNet team, I think we're also trying to make an effort in this direction to bring together this collective knowledge of the community of researchers, practitioners, policymakers through videos, through notes, and even though that might be a drop in the ocean, but we hope it's a step in the right direction. Thank you again to our moderator, Dr. Chaudhuri, for supporting us throughout, and to all the panelists and the speakers, even in the video, Dr. Chaudhuri, Dr. Narayan, Dr. Saiyed, Mohammad, Ameel, Madhavi, also Bhanupriya Roy from Behan Box, Sanita Ji, the ASHA worker we spoke to, Neeta Joy from ACT Grants, and of course, Sanjeev from Step 1. A big thank you to all of you. As a plenary conversation wouldn't have been a success without your participation and your support. Lastly, we are also grateful for all the attendees who could join us this evening, and we understand this has been a slightly longer conversation. So we also hope to see you in other plenaries that are upcoming in the following week, and my colleague Rohan has already posted about that in the chat box. Once again, thank you for joining us for this discussion, and have a great evening, everyone.